Hello and a warm welcome to everyone. The topic that I'm taking today is inflammatory bowel disease. It comprises of these two most important diseases, that is ulcerative colitis and Crohn's disease. So inflammatory bowel disease, it is a very important topic for theory, viva, also for the PG entrance MCQs. Inflammatory bowel disease, they are chronic inflammatory conditions which result because of the complex interactions between the gut microbiota and the host immune mechanisms, and this occurs in genetically predisposed individuals. So the basic defect is the dysregulation of mucosal immune response. This IBD, it is seen more commonly in the females than males, and amongst the ethnic groups it is seen more common in the Caucasians and the European Jews. In developed countries, it is more commonly seen than the developing countries like ours. And the age group that it involves, again, it is important. It is seen more common in the teens and the early 20s. So adolescent age group and the early 20s, they are most commonly affected. So before we go into details of Crohn's and ulcerative colitis, we shall see a little bit about the pathogenesis of these two diseases. So in the pathogenesis, there are two important factors. First is genetic factors, and additionally there is environmental factor. So in the genetic factor, the important genetic mutations that you have to remember. First is the NOD2 polymorphisms. So NOD2, it is a gene which codes for a protein NOD2, and this protein is present inside the cell cytoplasm. So it's an intracellular receptor which senses the presence of any pathogen. So this recognizes the peptidoglycans on the bacteria, and then this gene, it is seen in the this protein is seen in the Paneth cells, and normally it mounts an immune response against the bacteria or pathogen. So when it is mutated, then the immune response, the mucosal immune response becomes defective against the bacteria, and sometimes it can exaggerate the mucosal immune response. So that results in chronic infection and inflammation in the gut, leading to the inflammatory bowel disease. NOD2 polymorphisms, they are seen more with Crohn's disease than ulcerative colitis. Similarly, there is another mutation in the two genes ATG16L1 and IRGM. These two genes, they are important for the autophagy. Now autophagy, it deals with the autophagosome formation, and autophagy is an important mechanism in the body's homeostasis. It is used to clear the damaged organelles and also to remove the intracellular pathogens. So when these two genes, they are mutated, then again it will lead to defective autophagy. There will be increased cellular stress, and also there will be increased immune mediated damage. So again it is associated with inflammatory bowel disease more with Crohn's disease than ulcerative colitis. Next we come to the mucosal immunity alterations that occur in inflammatory bowel disease. So to understand this, first we should know a little bit about the normal mucosal immune response that occurs in the intestine. So the gut microbiota, it is present on the mucosa, and it penetrates the epithelium. In that there are the dendritic cells. Dendritic cells, they cause the conditioning of the mucosal immunity. So the dendritic cells, they activate the regulator T cells, which promote the anti-inflammatory mechanisms via cytokines like interleukin 10, transformic growth factor beta, and also it suppresses the CD4 effector T cells, which otherwise cause the activation of T helper 1 cells, T helper 2 cells, and T helper 17 cells. So in this way, the gut microbiota is helping in conditioning of our mucosal immune system. So this is the normal. Now what happens in inflammatory bowel disease? There is abnormal T helper 1 response. So in Crohn's disease, I will explain you later that the granulomas are formed in the serosa and submucosa, in all the layers granuloma can be seen. So we also know that granuloma is formed by the T helper 1 cell. It's a type 4 hypersensitivity with important role of the T helper 1 cells. So when there is abnormal Th1 response, it results in Crohn's disease, and in which granuloma are seen. When there is abnormal T helper 2 cells response, then that results in ulcerative colitis. It is associated with ulcerative colitis. Then there are interleukin 23 receptor polymorphisms, which can be seen in both ulcerative colitis and Crohn's disease. And interleukin 23 receptor mutations, they stimulate the Th17 response. And the Th17 response, there is neutrophilic infiltration. And we also know that neutrophilic infiltration is more commonly seen in ulcerative colitis. So interleukin 23 receptor polymorphisms, they are also more common with ulcerative colitis as compared to Crohn's disease. Then HLA association can also be seen with both these diseases, and I will tell you later that there are many HLA associated diseases which are seen in the form of extraintestinal manifestation in both these diseases, like ankylosing spondylitis, uveitis, sclerosing cholangitis. So ulcerative colitis, it is more associated with HLA DR2, while in Crohn's disease there is association of HLA DR1 and DQW5. So these again you have to remember for the MCQs. And lastly, there is hygiene hypothesis. So in hygiene hypothesis, I already told you that the gut microbiota, we in the childhood we get exposed to various microorganisms through the food we eat, but we know that now there are increased hygienic conditions. There is a use of preservatives, and the food is clean. So because of that, that early exposure to microorganisms is sometimes lost. So normally that microorganisms which get exposed to the gut very early, so they condition the mucosal immune system via the epithelial dendritic cells. But if there is absence of that early exposure, then at a later stage this intestinal mucosa will get exposed to these microorganisms. Then there will be inappropriate immune response to these microorganisms that can lead to chronic inflammation and inflammatory bowel disease. This change in the flora of intestine because of these increased hygienic conditions, this is known as dysbiosis. So this we should remember that these microorganisms, this early exposure to microorganisms and this microbiota is important for conditioning of our mucosal immune response. So when this initial exposure is absent, leads to dysbiosis and ultimately aberrant immune response to the gut microbiota. Some other environmental factors are presence of smoking and appendicectomy. This increases the risk of Crohn's disease while it decreases the risk of ulcerative colitis, because this smoking causes the decreased Th2 helper cell response. So that has somewhat protective role in ulcerative colitis while it increases the Crohn's disease. Now intake of OCPs is associated with increased risk of Crohn's disease. So again this can be asked in the MCQs. So these are the important points in the pathogenesis of inflammatory bowel disease. Now we proceed to comparison between these two entities, ulcerative colitis and Crohn's disease. So they have got some similarities but many differences as well. So let's start. So ulcerative colitis, most important site involved. Site involved in ulcerative colitis is colon and rectum. So the disease, it goes retrograde. It starts from the rectum and goes upwards in a continuous manner. This is very important. It involves the colon in a continuous manner, and it does not involve, it involves the rectum and colon and does not involve the ileum. But sometimes when there is lot of inflammation, then it can involve the ileum, and that is known as backwash ileitis. And backwash ileitis, it is seen in less than 10% of the cases. So you have to remember that disease starts in rectum. Rectum is always involved, and then it proceeds towards the colon. Most commonly involved sites are rectum and sigmoid colon. And in the Crohn's disease, any part of the GIT from mouth till anus can be involved, and most common sites are terminal ileum and colon. And the important point is that rectum is spared, and most common site is terminal ileum. Another important difference is there are skip lesions in case of Crohn's disease. So Crohn's disease involves the intestine in a discontinuous fashion. So here you can see it is involving some areas and sparing other areas. So these are known as skip lesions. Involving the gut in a discontinuous fashion is skip lesion, and involving the gut in continuous fashion is seen in the ulcerative colitis. Another important difference is that when there is ulcerative colitis, it involves the mucosa and submucosa by the inflammatory process, while in Crohn's disease, all the layers are involved: mucosa, submucosa, muscle layer and serosa. So that inflammation is known as transmural inflammation. Next important point is that since the inflammation in Crohn's disease is transmural, so there is ongoing inflammation in all the layers, then they will be healing by fibrosis. So the wall is thickened in case of Crohn's disease, while in ulcerative colitis, since it is involving only the mucosa and submucosa, so the wall is generally thin. So a single tip to remember is that ulcerative colitis involves two sites, that is colon and rectum, and also involves two layers, that is mucosa and submucosa. Crohn's disease can involve all of the GIT and all of the layers of intestine. This is just to remember if you wish to learn like that. Next important difference is that creeping fat. Now creeping fat is seen with Crohn's disease. Why? Because in Crohn's disease, I told you that there is transmural inflammation. So inflammation is seen in all the layers including the serosa. So because of the inflammation on the serosa, sometimes the fat, it creeps and wraps over the serosal surface. This is known as creeping fat or fat wrapping. This fat wrapping is absent in case of ulcerative colitis. So you have to remember that. So C for C, that is Crohn's disease, and creeping fat, they come together. Next is ulcers. Ulcer is very important. So ulcers, they are the morphological gross features in case of ulcerative colitis and Crohn's disease, but there is difference in morphology. In Crohn's disease, the ulcers initially they are pinpoint, and they are known as ephthoid ulcers. Now these pinpoint ulcers later on they coalesce together and then they form linear and serpentine ulcers, snake-like serpentine. So this is a very important point, will be asked in the exams. So serpentine ulcers, it is seen in case of Crohn's disease. Now in ulcerative colitis, the ulcers are there and they are variably sized, irregular in shape. Next important point regarding the ulcer, the differentiating point is that in Crohn's disease, the ulcers, they are deep and knife-like. So the ulcers, they will be seen penetrating the mucosa, submucosa, then muscle layer. They can even, that's why they can even lead to fistula formation later on if they are penetrating all the layers. So the ulcer in Crohn's disease are deep. You remember this point. While the ulcers in ulcerative colitis, they are just superficial. Next important point is cobblestone appearance. So when there is ulceration, deep ulcer seen in Crohn's disease, the mucosa, the spared mucosa in between these ulcerated regions, it gets edematous. So because of that, there is a cobblestone appearance. While cobblestone appearance is not seen in ulcerative colitis. So how the cobblestone looks like? This is the cobblestone pathway, and this is cobblestone means there are stones and there are depressions in between this. So similarly in the Crohn's disease, we can see this is the intestine, gut. We know that in Crohn's disease there are skip lesions, means this area is uninvolved and this area is involved. This is the involved area, and in this involved area you can see just like this cobblestone, here again there are these elevated edematous areas, and in between these are the ulcerated areas. You can see these red lines, these are all the ulcerations. So these are all the ulcers, these red lines, and in between there is the edematous mucosa. This is the cobblestone appearance. Again, this is the colonoscopy, and in this again we can see. So this is the endoscopic view, and it is showing this cobblestone appearance. This is the elevated mucosa, and this is the ulcerated areas. So this is a very important difference that you should know regarding the ulcers and the cobblestone appearance. Next point is presence of pseudopolyps. So the ulceration, there is ulceration in ulcerative colitis, and the mucosa which is adjacent to the ulcers, they will regenerate, and that will cause the presence of pseudopolyps. So there is an ulcer, and the mucosa which is adjacent to ulcer, it will regenerate and appear like polyps, but they are not true polyps. They are pseudopolyps which have arisen because of the inflammation and ulceration. And pseudopolyps can also be seen in case of Crohn's disease, but the distribution of pseudopolyps will be diffuse in case of ulcerative colitis, because I've told you that in ulcerative colitis there is a continuous involvement of the gut. So all of the gut is involved. So pseudopolyps will also be continuous. They will be present diffusely. While since in Crohn's disease, I told you that there are skip lesions, so the pseudopolyps will also be seen in a patchy distribution. So pseudopolyps are more associated and diffuse in case of ulcerative colitis. So this is a picture from ROBBINS. This is again the gut, the mucosal surface, and these are the pseudopolyps. And sometimes the mucosa over the pseudopolyps, they join together to form mucosal bridges, like in this picture again from the ROBBINS. So we can see the mucosa over the pseudopolyps, like this pseudopolyp and this pseudopolyp. The mucosa, it joins together, forming the mucosal bridge. So mucosal bridge, again this is mucosal bridge. Mucosal bridge is a feature of ulcerative colitis. This again you should remember. Pseudopolyps and mucosal bridge, they are more seen in ulcerative colitis. Now again this is an image of creeping fat. So this is the mesenteric fat, and this is the gut, in the serosal surface of the gut, and this fat is creeping over the serosal surface. So this is seen in case of Crohn's disease because there is transmural inflammation and associated serositis. So this fat wraps over the serosal surface. So you have to remember C for C. Again this picture from ROBBINS, and it's from Ackerman, and we can see that these are the pseudopolyps seen in case of ulcerative colitis, and these are the mucosal bridges. Again these are the pseudopolyps. So you have to remember these important points. They are very important for the MCQs also. Now next, when we talk about fissure and fistulas, so fissure and fistulas and sinuses, they will be seen more common with Crohn's disease, because there we have seen that the ulcers, they are deep, knife-like. Sometimes they can reach up till the serosa, they can perforate, and then they can form fistulas. So then when the ulcers become deep, first they become fissure, then they can communicate with other gut wall, and they can form the fistula, and then they can also form sinuses, perianal sinuses, fistulas. They are common in case of Crohn's disease, so you have to remember that. Next is fibrosis. So fibrosis in wall, it is very common with Crohn's disease. Again, why? Because there is transmural inflammation, and inflammation, when it heals with fibrosis. So it is common with Crohn's disease, and it is rare in ulcerative colitis. Again, stricture formation, because here there is a lot of fibrosis in Crohn's disease, and the wall is thickened. There is transmural inflammation. So there will be narrowing of the lumen of the gut, and this is known as stricture. So here we can see this is the lumen, and here it is narrowed. Here in this area, this is the lumen is narrowed. This is stricture. So stricture is seen more common with Crohn's disease, and this stricture, when we do barium studies, then it is seen as string sign of Cantor on radiology, because the barium will show a filling defect here. So it is seen as a string sign of Cantor. Again, you see this, these are the bowel loops, and here this is loop. So barium has filled here, but here it is, you can see it as a thin line. So this is the string sign of Cantor, because here the bowel wall is narrowed because of stricture formation. So this is string sign of Cantor, and you have to remember this for the MCQs. And again, this another thing is, in the Crohn's disease, the lumen is dilated and not narrowed. So it is sometimes called garden pipe appearance or lead pipe appearance. And in some books, you will see that in Crohn's disease, it is written it has hose pipe appearance, because hose pipe, it is a narrow pipe. So because here the gut lumen is narrowed, so it is also called hose pipe appearance, while here it is called garden pipe in ulcerative colitis and lead pipe. Again, you see this is a gross specimen of a bowel. This part is the normal intestine, and these are the normal mucosal folds. We can see this is also bile stained, and here you can see the wall abruptly is it's thickened. You can see the increased thickness. So because of the increased thickness, the lumen is narrowed, and this is stricture formation here. So here in all these part, the lumen is narrowed, and when we will do the barium studies, it will be seen in as the string sign of Cantor. Now next, I told you that lumen of ulcerative colitis, it is dilated while narrowed in case of Crohn's disease because of the thick fibrosed wall of the intestine. Next, in ulcerative colitis, sometimes when there is overwhelming inflammation, there is a lot of inflammation that will involve the nerve plexuses in the intestine. So that will cause the toxic megacolon. The colon is dilated, and it is seen as a life-threatening complication with risk of perforation. And toxic megacolon is considered, the criteria is the colon dilatation of more than equal to 6 centimeter. You have to remember this value. So the wall becomes dilated, wall becomes thin, and clinically the patient comes with a distended abdomen. So this is seen with ulcerative colitis. You have to remember toxic megacolon. So this is the image from the various internet sources. So in this radiological image, you can see that there is loss of ostrations of the colon, the loss of any folds. So the colon has become very much dilated. This is megacolon. Again, you see the loss of ostrations and megacolon. This is a gross picture, per-operative picture after removal of the colon. So when there is toxic megacolon, it has to be removed. So you can see that this is heavily dilated. So this is toxic megacolon seen in ulcerative colitis. Next, some microscopic differences. So I have already told you that in ulcerative colitis there is transmural involvement. That is, all of the layers are involved. You know what are the layers of intestine? First is mucosa, then there is submucosa, then there is muscularis layer, and last is serosa. So all the 4 layers will be involved in Crohn's disease, and there will be mostly mononuclear cell inflammation in case of Crohn's disease. Lymphocytes, plasma cells, these are seen in all the layers. While in Crohn's disease, mucosa and submucosa, they are mainly involved. So only the superficial involvement is there. The ulcers, again I told you already, we will be seeing the ulcers in microscopy, which layers they are involving. So in ulcerative colitis, they are superficial, seen in the mucosa and submucosa. So in the Crohn's disease, these ulcers are very deep, knife-like, and when they are deep, then it is known as fissure. Ulcers, when they become deep, they are called fissures, and then they further go down, then they can perforate the serosa, and they can communicate with other bowel loops. It forms a fistula. So fistulas, they are more common in case of Crohn's disease. Next, very important point, granulomas. So I told you in the pathogenesis that in Crohn's disease, there is active Th1 cell response, which is present. So granulomas are seen because of this Th1 response, and these granulomas are characteristically non-caseating. We know that in tuberculosis, the granulomas, they are caseating. Here in Crohn's disease, they are non-caseating. So they can be seen in any layer of the bowel, and commonly seen in submucosa, so in serosa. Granulomas are characteristically, they are absent in ulcerative colitis, you have to remember. Next, fibrosis, serositis, both will be marked in case of Crohn's disease because there is transmural inflammation. So there's more inflammation, more fibrosis, and serositis because it is inflammation is present up to the layer of serosa. So fibrosis, serositis will be seen in Crohn's disease, while fibrosis serositis is absent to mild in case of ulcerative colitis. Next, there is cryptitis, cryptapsis in case of ulcerative colitis. Cryptitis means that neutrophils, they are seen at the base of the crypt. You know, in the intestine, this part is known as the crypt, and this is the villi. Crypt and villi, crypt and villi. So in the base of the crypt, you can see this collection of the neutrophils. So these are neutrophils at the base of the crypt. This is known as cryptitis, and cryptapsis means that in the near the crypt, these neutrophils, they accumulate on the surface of the epithelium in the crypt area. So this is cryptapsis, again neutrophils. So I have told you that in ulcerative colitis there is Th17 response, which is more prominent. So that causes the neutrophilic infiltration. So neutrophils, they are more commonly seen in ulcerative colitis. Cryptitis, cryptapsis, they are more common in ulcerative colitis. Besides this, crypt distortion will be seen in ulcerative colitis, although it is also seen in Crohn's disease, but more seen in ulcerative colitis, crypt distortion. Okay, now cryptitis and cryptapsis, they are less common in case of Crohn's disease. Rather, we find the mononuclear cell aggregates, basically lymphocytes, plasma cells, they will be seen in all the layers of the intestine. And also you can note that in these images I have also shown the ulcerations. This is the area where the epithelium is absent. This is an ulcerated area. So these are again the important points of differences in microscopy. Next, edema. So I have told you that edema, which was causing the cobblestone appearance in gross, so that was seen in Crohn's disease. So here also the edema is more commonly seen in Crohn's disease on microscopy, while less common in ulcerative colitis. Next, we come to the clinical features. So first we covered the gross, then microscopy, now clinical. In clinical, the ulcerative colitis and Crohn's disease, they have got a similar clinical presentation. So they are chronic and relapsing diseases, and they are intermittent attacks of bloody diarrhea with mucus, which is seen in both conditions. The anemia and blood loss is more in case of ulcerative colitis than in case of Crohn's disease, while malnutrition is more marked in case of Crohn's disease because the small intestine is more involved, so there is defective absorption of vitamins and nutrients, so that leads to malnutrition in Crohn's disease. Risk of malignancy, very important. Risk of malignancy is tenfold more in case of ulcerative colitis. So there is risk of carcinoma colon, which is seen in ulcerative colitis. In Crohn's disease, when there is colonic involvement, then malignancy can be seen, but it is very rare. So whenever it comes to risk of malignancy, you have to remember ulcerative colitis. Ulcerative colitis has a risk for carcinoma colon. Extraintestinal manifestation, I told you that there is HLA association in both these diseases. So both of them, they can be associated with ankylosing spondylitis, then sacroiliitis, uveitis. These can be seen in both. And in ulcerative colitis, migratory polyarthritis, skin lesions can be seen. And in Crohn's disease, we can see sclerosing cholangitis. So basically, in both extraintestinal manifestation are seen in the form of these autoimmune diseases. Then there is lastly diagnosis. So for diagnosis, there in the serum we can do the anti-Saccharomyces cerevisiae antibodies, which are positive in 10 to 15% of the cases of ulcerative colitis, and while it will be seen positive in 60 to 70% cases of Crohn's disease. So ASCA antibodies, they are more important for the Crohn's disease. Next antibodies are p-NK antibodies. So p-NK antibodies, they are seen more in case of Crohn's disease and will be seen positive only in 10 to 15% cases of. So p-NK is P anti-neutrophilic cytoplasmic antibodies. It is seen positive in 60 to 70% cases of ulcerative colitis, while only in 10 to 15% cases of Crohn's disease it will be seen. So you have to remember, for ulcerative colitis the antibody is p-NK, and for Crohn's it is ASCA. Now when we do biopsy, it is needed for the diagnosis. So endoscopic guided biopsy will be seen, and all the microscopic features that I told you, the differences, so they will be seen. Now for the treatment, the ulcerative colitis shows better response to surgery than Crohn's disease, and medical management is almost same in both, which is anti-inflammatory drugs, immunosuppressant, then immunomodulators like anti-TNF antibodies. So these were all the differences and similarities between ulcerative colitis and Crohn's disease. This is a very important topic. So I have tried to cover all the important points. So if there are any questions, that you can ask me in the comment section. And thank you for your patient listening. Thank you very much.